Okay, we'll go through the endocrine system part 2 now, which is the second part of this lecture. And again, I've highlighted some specific slides for you to make sure you pay particular attention to. Thyroid gland. We'll talk about some of the thyroid hormones. Thyroid gland located in the anterior portion of the neck, just below the thyroid cartilage, the point of the larynx. You can see the cricoid cartilage as well as located inferior and actually starts at the level of the cricoid cartilage. You can see the left and right lobes, and then the center of which the thyroid gland referred to as the isthmus, and then the blood supply coming off of a branch of the aorta. See, it supplies the inferior thyroid artery, supplies blood supply. We also can see as it branches off of the common carotid artery, you can see the superior thyroid artery as well that supplies blood supply to the thyroid gland. So a very vascular organ. Surgery for thyroid gland and removal of the thyroid gland can sometimes be complicated by the blood supply, which has a pretty brisk arterial flow, and its proximity to the heart makes that vessel under an enormous amount of pressure, so can sometimes complicate thyroid surgery. Thyroid gland lies anterior to the thyroid cartilage of the larynx and consists of two lobes connected by a narrow isthmus. Thyroid hormones increase metabolic rate of cells. It increases metabolic rate, which will increase the caloric requirement of cells. So a person that is secreting an excessive amount of thyroid hormone or overdosing on a thyroid supplement will lose weight because it increases the metabolic rate. It will increase caloric requirement of the cell, thus the person will burn more calories. Thyroid gland contains numerous thyroid follicles, hollow spheres that line the simple cuboidal epithelial cells. Just mention that because I know you're already over the epithelial tissue layers, but simple cuboidal is what we see in the system there. There is a follicle cell that surrounds a follicle cavity that holds a colloid type matrix, this is basically a fluid that contains large quantities of undissolved proteins. The network of capillaries which surround these follicles will deliver nutrients and or regulatory hormones that will stimulate the production of these hormones. Thyroid globulin molecule contains the acid tyrosine. Formation of thyroid hormones intimately involves iodine ions that are absorbed from the diet at the digestive tract and delivered into the thyroid gland in the bloodstream. Iodine ions diffuse to apical surfaces of the follicle cells. We'll see that it's converted and activated to form iodine and the enzyme thyroid peroxidase. Now, there are two released substances, molecules, from tyrosine molecules. There are the hormone thyroxine, T4, which contains 4 iodine ions, and then there is T3, which contains 3 iodine ions. This is the physiologically active form of thyroid. This is the one that's going to go around and increase the metabolism inside the cells. If you ever have to have your thyroid checked, a doctor typically will order a thyroid panel, which includes the thyroid stimulating hormone to make sure that the stimulating hormone is working, and then we'll order a T4, a T3, and a T4. Now, if your T3 is elevated, it's not a test question, but just so you know, if your T3 is elevated, what would you expect your thyroid stimulating hormone to be? High or low? Feedback mechanism, think about it. T3 is high. Do you need more TSH if your T3 is high? No. So by feedback mechanism, your TSH should be low if your T3 is high. Make sense? Okay, so that's how the system works. And so if we want to see if your thyroid gland, now it's some other things we look at too, but just basically speaking, if I want to see if your thyroid gland is working, now if your T3 is low, then I expect to see the TSH high. If I don't see that balance, or if everything is normal, got the appropriate number of T3, appropriate number of TSH, no problem. But if the person has a high T3, you expect to see a low TSH. Now, that person can have a high T3 because they have thyroiditis, Hashimoto's disease. You'll learn about that in pathology, but it's a condition where you get inflammation in the thyroid gland, and you start secreting too much T3, and the person's metabolism picks up. They have no TSH. TSH is measured at 0 because they don't need any TSH. The thyroid gland is secreting enough free T3 on its own, and so you don't need any TSH. One of the indications of, or one of the diagnostic criteria for a person that has hyperthyroidism. Person hypothyroidism has little or no T3, little or no T4, but their TSH is really, really high because the body is sensing, I need more T3, T4, so hypothalamus secretes a thyroid stimulating hormone, but you're not getting from the thyroid gland, you're not getting the T3 that you need, so that person has hypothyroidism. So that's an example of how using diagnostic labs can help you. It shows you the feedback mechanism, but it also shows you how the system works. So iodine ions are important as well. They're actively transported to the thyroid gland for diagnostic studies. If you want to measure the function of someone's thyroid gland, you can radiate or irradiate a molecule of iodine, and you can inject it in a person's bloodstream. It will go directly. It will not pass go. It will not collect $200. It will go directly to the thyroid gland. Now, if a person has Hashimoto's disease and has thyroiditis, you can give them a little bit of radioactive iodine. It'll go directly to the thyroid gland, and it'll wipe out, it will ablate the thyroid gland because the thyroid gland is so specific for absorbing iodine that you can use it to diagnose a problem, and you can also use it in therapeutic management of a problem. Again, these hormones actively transported iodine, stimulated by thyroid stimulating hormone, actively transported to the thyroid follicle cells. That's not a test question, that's just one of those FYI type things. Okay, cells, C cells in the thyroid gland produce something called calcitonin. Calcitonin helps regulate the concentration of calcium in bodily fluids, especially during childhood when it stimulates bone growth, mineral deposition in the skeletal system, and in pregnancy. 2 times, childhood and in pregnancy, and it reduces the loss of bone mass. These are the parathyroid hormones. As you can see them located in the thyroid gland. Parathyroid hormones, normally 2 pairs, parathyroid glands embedded in the posterior surface of the thyroid gland. A lot of times when people have thyroid surgery done for whatever condition, they will leave one of the lobes, so the person will be able to produce actively from the parathyroid glands. They stimulate osteoclast accelerating mineral turnover, inhibit osteoblasts. Osteoblasts lay down new bone, reducing the rate of calcium deposition of bones. It enhances the reabsorption at the kidneys, reducing urinary loss. It also stimulates the formation and secretion of calcitriol at the kidneys. The effects complement that of the parathyroid hormone for calcitriol. One of the major effects of calcitriol is to enhance parathyroid hormone in the absorption by the digestive system of calcium. That's in red, or that's highlighted rather, that's orange. But so the effects of calcitriol complements the effects of parathyroid hormone. The major effects of calcitriol, again, enhance parathyroid hormone, and then the absorption by the digestive tract of calcium. Levels of parathyroid hormone inadequate PTH production condition is called hypoparathyroidism, and it leads to low concentrations of calcium in the bodily fluids. Most obvious simple terms, it involves a neural and muscle activity. Got to have calcium there. Conductive activity of the heart, conductive activity in the nervous system dependent upon calcium, and so if we have low levels of absorption of parathyroid hormone, we get decreased calcium layer. We get hyperparathyroidism, we get concentrations of calcium become abnormally high, bone grows thin and brittle. Left out calcium on there. Concentration becomes abnormally high. Concentration of calcium becomes abnormally high. CNS functions become depressed, nausea and vomiting occurs. You will see in individuals that have elevated levels of calcium or have lower elevations of calcium, the signs and symptoms kind of look the same. The person may still have muscle twitching. They may still have facial twitching from hypo or hypercalcemia. But again, you can see where the hyperparathyroidism or parathyroidism, abnormalities in the parathyroid gland involve calcium concentration. And especially in the conductive activity of the heart, calcium is required for normal conduction. In the adrenal glands, function of the adrenal glands produces 24 or more steroid hormones collectively, the adrenal corticosteroids. The adrenals are located above the kidneys, so they have a suprarenal location. The adrenal cortex stores lipids, especially cholesterol and various fatty acids. The adrenal cortex manufactures steroids. They're called adrenal corticosteroid or corticosteroids. Corticosteroids are vital. If the adrenal glands are destroyed or removed, the individual will die unless they are receiving exogenous corticosteroids. The person has to receive corticosteroids for us to survive. The cortex of the adrenal gland is divided in 3 parts: zona glomerulosa, and the zona folliculata, and the zona reticularis. Sounds like the 3 ships that Columbus sailed on. Now, in the zona glomerulosa, we see the outer region of the adrenal cortex produces mineralocorticoids. The primary mineralocorticoid is aldosterone. This is the principal mineralocorticoid. Aldosterone secretion stimulated by the conservation of, or secretion stimulates the conservation of sodium. If we conserve sodium, and we eliminate potassium, then we also conserve fluid. So aldosterone, if it holds on to sodium, then it will also hold on to fluid. Causes retention of sodium ions in the kidney, sweat glands, salivary glands, pancreas, preventing loss of urine, loss of sweat, saliva, and digestive secretions. The effect at the kidneys is most dramatic when normal levels of ATH, antidiuretic hormone, are also present. The folliculata produces steroid hormones collectively known as glucocorticoids. The endocrine cells are larger and contain more lipids than those of the zona glomerulosa, and then lipid droplets in the cytoplasm are pale, foamy in appearance. When stimulated by adrenocorticotropic hormone, then we see from the anterior pituitary gland, we see the zona follicular will secrete primarily cortisones or hydrocortisone, which you may be familiar with as a synthetic product, but along with smaller amounts related steroid corticosterone. The liver converts some of the cortisol to cortisone. Glucocorticoid secretion is regulated by a negative feedback mechanism, as we've discussed before. Now, glucocorticoids accelerate the rate of glucose synthesis and glycogen formation, especially in the liver. We see the adipose tissue is also involved, responds by releasing fatty acids in the blood and other tissue, and it begins to break down fatty acids and protein glucose. Glucocorticoids have also shown a dramatic anti-inflammatory effect, and thus that's why we see it used a lot in synthetic products. Synthetically produced glucocorticoids are used in therapeutic management of a variety of diseases, autoimmune processes, inflammatory processes. If you get a flu or if you get bad sinusitis and you have inflammation, we can administer glucocorticoids or corticosteroids, whichever name you like to use, and it will decrease the inflammation and you'll feel better right away. Now, it didn't treat the problem. The problem was the virus or the bacterial infection that caused the sinusitis, but you'll feel better because it decreases the inflammation. That's the downside to using steroids. Steroids will decrease inflammation. They make you feel better, but they haven't fixed the problem. That's why we can't use glucocorticoids to treat some problems. If you have a massive infection and we put you on glucocorticoids, you'll feel fine, you'll go home, and you'll feel fine. The infection is just running like crazy. And so it causes a lot of long-term problems, and it can mask the disease process. Now, sometimes you don't have a choice. If you have an autoimmune process, you receive a heart transplant, you need to keep the heart. If you don't keep the heart, you're going to die. So we put you on massive dosages of glucocorticoids or corticosteroids because the inflammatory process, the body tries to reject this foreign heart. Heart didn't belong to me. Doesn't recognize the glycocalyx. Remember glycocalyx and the protein receptors, all those recognition factors. Doesn't recognize it, so they look at the heart. The body looks at the heart as an antigen, a foreign agent, and so it starts to attack it. So we have to suppress our immune system, suppress the inflammatory response, and so we administer massive doses of glucocorticoid to suppress the immune system and to decrease the inflammation. course, there are side effects to massive dosages of glucocorticoids. They elevate your sugar level. They make you increase a lot of body fat. So it's some downsides to using massive dosages of glucocorticoids. But they're important. If you get poison ivy, nothing better than using a little glucocorticoid where you got poison ivy. You come in with an anaphylactic reaction. You ate some shrimp and you weren't supposed to eat seafood, and you're swollen and you look like, you seen the movie Hitch? That's a great scene in Hitch. But that's what happens. Boom, you need to get a shot of glucocorticoids, okay? So it's important. We use it in therapeutic management, but we've got to be careful with it. Zona reticularis forms a narrow band bordering the adrenal glands. The adrenal cells of the zona reticularis are basically in a folded network, fenestrated with blood vessels, fenestrated because we want those hormones to be able to get into the system right away. Zona reticularis, the adrenal androgens stimulate the development of pubic hair in adults. It promotes muscle mass, promotes blood cell formation, supports libido. That's all produced in the zona reticularis. Again, direct entry into the bloodstream. The adrenal medulla contains two populations of secretory cells. One produces epinephrine, adrenaline. The other one produces norepinephrine, noradrenaline, under the control of the sympathetic nervous system. And remember, sympathetic nervous system, that's the fight or flight system. We'll do the nervous system. I'll change your syllabus. I think we'll do urinary system next, and then we'll do the nervous system at the very end to put all that together. It doesn't make sense to do the nervous system without doing the urinary system before that. So we'll do that first, and then we'll do the nervous system. That's a little aside note. The effects of epinephrine, norepinephrine, metabolic changes follow the release of catecholamines of epinephrine, norepinephrine, peaks in about 30 seconds. Even if we administer it, and we do administer epinephrine for therapeutic management, you have a heart attack, we need to stimulate your heart, going to slam you with several dosages of epinephrine to try to stimulate your heart, but it only lasts for a short period of time. So every 5 minutes, we got to be bolusing you, every 3 minutes actually, got to be bolusing you with epinephrine. And so the effects of it is short-lived, 30 seconds. Something scares you, your heart rate jumps up, but then within a few seconds, a minute, it's going to calm back down again because the effects are short-lived. But they do trigger the immobilization of glycogen. Remember, fight or flight. So I need my heart rate up because I'm going to run or I'm going to fight. I also need glucose because if I'm going to run, I need plenty of sugar. If I'm going to fight, I need plenty of sugar. So we see this surge in mobilization of glycogen reserves, which will break down and produce sugar. We see a combination of release of both muscle strength and endurance is enhanced by epinephrine and norepinephrine. And then there is the pancreas. Pancreas has an exocrine and an endocrine function. The exocrine function, 99% of the pancreatic involves clusters of glands in the pancreatic acini. These are responsible for producing enzyme-rich fluids that reach the lumen of the digestive tract and facilitate digestion, the breakdown of carbohydrates, and the breakdown of fats. Now, in the digestive process, as Dr. Sloan, I'm sure, alluded to, in the digestive process, we know amylase and lipase also secreted in the mouth. So you get a little early process of digestion going on, but no absorption takes place until you get into the small intestines. No absorption takes place until you get into the small intestines. Everything else, mechanical digestion, a little chemical digestion, which continues when you get into the stomach, a little more mechanical digestion, but absorption takes place when amylase, lipase reacts on those substances in the small intestines, and then absorption will take place. Now, where does that come in at? Remember, the pancreatic duct comes and releases in the duodenum at that little papillae. That's where these exocrine substances will be released and facilitate digestion. The endocrine function of it, the endocrine function is the production of insulin. Insulin, as we already talked about, important peptide hormone released by the beta cells. Remember, insulin by beta cells, glucagon by alpha cells. Beta cells, when glucose levels exceed a certain level, get above 110 or so, then we'll see the release of insulin. Important because the effects, it enhances the glucose absorption from the blood stream. Insulin is a peptide hormone, exerts its effect on cellular metabolism, series of steps that begins when insulin is bound to receptor proteins in the cell membrane. Binding leads to the activation of receptors which function. And again, those steps, that first illustration where I talked about the activation of the receptors using kinase, allyl cyclase as well, phosphorylation of enzymes, all of those processes in the steps that we'll see with insulin. One of the most important effects is the enhancement of glucose absorption and utilization. Cells in the brain and the kidneys, priorities, cell, kidneys, brain, also the heart, but the cells in the brain and kidney, the cells are lining the digestive system with red blood cells, lack insulin receptors. These cells are called insulin independent because they can absorb and utilize glucose without glucose stimulation. These high priority levels, these high priority areas and organs will absorb glucose directly and do not require insulin. Now, the effect of insulin on target cells. Stimulation of amino acid absorption and protein synthesis, acceleration of glucose uptake in target cells, acceleration of glucose utilization, and enhanced ATP production, and the stimulation of glycogen formation. This is particularly seen in skeletal muscles and in the liver. Acceleration of glucose uptake is the primary effect of insulin. Multiple membrane cell systems. Every cell in our body requires glucose, again, requires insulin to allow the glucose to be absorbed by the red blood cells. The only exceptions to that, like I said, were the brains and the kidneys, which can absorb it directly. The rate of glucose is proportional to the availability. When more glucose enters the cell, more insulin is used. Secondary messengers will activate key enzymes in the process to initiate the step. When glucose enters the cells, it stores it in the form of glycogen. Insulin stimulates the absorption of fatty acids, glycerols, and adipocytes, which store these components of triglycerides. Adipocytes also increase their absorption of glucose when excess glucose is used in the synthesis of additional triglycerides. And so in summary, function of insulin, secreted when glucose is abundant. The hormone stimulates glucose utilization to support growth and establishment of carbohydrates and or storage as glycogen and lipid triglyceride reserves. Accelerated use of glucose soon brings circulating glucose level within a normal level. Now, the disease condition, diabetes mellitus. Diabetes mellitus characterized by glucose concentration high enough to overwhelm the reabsorption capability of the kidneys. Now, the problem is not too much sugar. The problem is not enough insulin. Insulin, for some reason, is no longer being secreted by the beta cells in the pancreas. Beta cells are in the pancreas. For some reason, it's not being produced. You get abnormally high levels of glucose. The term referred to as hyperglycemia. You should know that definition, though I didn't test you on that. Hyperglycemia, elevated abnormally high levels of glucose. Glucose appears in the urine. We see glucose in the urine is referred to as polyuria. Diabetes can be caused by genetic abnormalities. For some reason, genetically, you didn't produce the beta cells to produce insulin. You can have a mutation can occur in the cells. You can get some type of an attack, a viral infection attacks the pancreas. You can have recurrent pancreatitis, alcoholics who drink a lot. That's redundant. In alcoholics, you can have recurrent pancreatitis. Recurrent inflammation will destroy cells of the pancreas. The person will develop an onset of pancreatitis. Now, diabetes mellitus, two types. Type 1, genetic, bad cells. Type 2, basically the person becomes obese. Their sugar requirements and the metabolism, the cells for some reason no longer are sensitive to insulin production. For example, remember you got to have receptors to be able to pick up the insulin in circulation. For some reason, the receptors are no longer sensitive to insulin. And because of that, we'll see the adult onset of diabetes as well. Again, obesity accelerates the onset and severity of certain types of disease. Many diabetic-related problems. Diabetes causes a condition. About to run out of time here. Diabetes causes conditions. We refer to this as in-vessel disease. Take a blood vessel. Blood vessels, the further you get away from the heart, you can look at this, the further you get away from the heart, the smaller the blood vessel gets. Okay? Look at the heart itself. The heart has coronary arteries. Left main artery big. As we get around the heart, it gets smaller and smaller. Diabetes causes end vessel disease. At the end of the vessel, that's where the disease starts at. The circulating sugar, glucose, begins to coat the inner lining of the blood vessel. And so the disease starts at the most distal portion of the blood vessel and works its way up. That's why you see diabetics begin to have problems with lower extremities. Circulation down in the lower extremities gets affected first. So the person may not have good circulation down in the feet. The nerves in the feet and in the legs don't get good circulation either. If you don't give good circulation to the nerves and the blood vessels, they don't work anymore. And so now, not only do they have bad circulation, but they can't feel their feet. So they stub their toe or they get bitten by an insect on the foot and they develop an infection. They don't even know it because they can't feel their feet. So that's why diabetics have a lot of problems with infection, because there's no circulation for the immune system to be able to get antibodies down there. For us to be able to give you antibodies, the antibodies have to get to the targeted area. If the circulation's not working down there, then the antibiotic's not going to get there. That's why it's very difficult to treat a diabetic foot ulcer, because it's hard to get high enough antibiotic concentration down there. That's why diabetic has diabetic neuropathy. The nerves don't work good. Diabetic nephropathy. The kidneys don't work well because circulation is not getting to these target organs. Diabetic retinopathy, very small blood vessels in the eye. The sugar coats those blood vessels. What happens? Another blood vessel will start to grow out. That works okay in some areas, but in the eye, you got to have a place for the lens to focus on. If the area gets crowded with blood vessels, you can't see. So diabetic retinopathy, the person can't see well anymore. There are a number. Cardiac disease, the problem with heart disease in a diabetic patient, number one, the nerves don't work well anymore. So if they're having a heart attack, they don't feel it. That's a bad thing. And then the other thing is this in-vessel disease. Started at the end, and the vessel gets disease going closer toward the bigger portion. In bypass surgery, how does bypass surgery work? You take blood from one area and you take it to another area. But if the vessel is diseased further down, where can you bypass to? So the bypass routes are already messed up by coronary artery disease because of diabetes, and so you can't do bypass surgery on them because the rest of the vessel is blocked as well. So diabetics have a lot of complications that are associated with it. Last hormone that I just want to talk about real quickly, and then we'll do the review, glucagon. And those of you who've done the review already, free to go. But glucagon, glucose concentrations fall below normal. Release glucagon and energy reserves become mobilized. So when glucagon binds to a receptor of a cell, the hormone activates the aniline cyclase we talked about before. And these are the primary effects of glucagon. Stimulates the breakdown of glycogen in skeletal muscle and in liver cells, stimulates the breakdown of triglycerides in adipose tissue, and stimulates the production of glucose by the liver. The results are a reduction in glucose use and release of more glucose into the bloodstream. So not only does it tell the body, look, we don't have enough sugar, got to stop doing whatever you're doing, and we got to conserve, but then it also will break down glucose reserves as well and make more available. Now, it is produced by, that should be highlighted, pancreatic alpha cells. Pancreatic alpha cells. Alpha cells produce glucagon, beta cells produce insulin. Okay? And you can read a little bit more about beta cells and alpha cells. We already talked about the autonomic nervous systems, sympathetic and parasympathetic nervous systems, how they enhance insulin release and glucose release. I'll let you go into another table here that shows you. That's out of your textbook, 18.6. Please review. Okay? Very good. May the force be with you. And for those of you who need to stay for another review, we'll do that after about 5 minutes here. We'll let everybody clear out.